Okay, we are officially recording, and welcome, Sandra. We'll do a little bit of our business meeting first, just with network type things, and all of you have the agenda. And again, if you want to print out the agenda in advance, if you're at home, we've got that on our web page, and you have your little handy dandy laminated cards now. Keep by your computer so you remember the password. Just a reminder too, we've been talking about the weight tracker and having programming related to physical activity and healthy eating, and I've got those grant dollars. So I've already started processing you guys the checks for your congregation. So if you do anything related to weight loss or healthy eating, you know, can be bringing in a speaker. I think it's Susan Leos's church. They're doing the Walk to Jerusalem now. Some of you may be doing that later in the spring. You may have newsletter articles about some of these topics. And so I don't care what it is, but we can give your church $200 a stipend. And then if it is some kind of something where you can use an incentive or have a raffle, we've got Fitbits to give out as well, and that would be 1 to 2 per congregation. So I don't want this money to go to waste, and we need to spend it by June. You don't need to have your activity completed by June, by the end of June, but at least have plans for it so I can, you know, kind of write down whatever, all the fun stuff you guys are doing. Or if you need more ideas, just send an email or give me a call, and we'll figure it out. Like at our church at Otterbein, we've started a walking club, so that's been, we were going over the summer, and actually when it was too hot, you'd think that would be the time we'd want to walk, but every day we were planning to walk, it was 90 degrees. And, so now we've worked out an arrangement with HCC where folks from our church can walk on the indoor track for free, and that's all year round. So that's been kind of a fun partnership with the community college. On the side, and for you folks at home, I can make these available to you guys too, either to pick up at the office or we can mail them to you. The Living Well devotional booklets that are available for Lent. We've got printouts, hard copies of those. And then a new resource called Faith and Health in the Bible, and looks like this. It's actually a 6-week Bible study that looks at the connections between faith and health. And again, you don't have to use it as a Bible study. You can take segments out to use for your newsletters. You can you know, do single lessons if that's something that's more appealing to you. So you don't have to use these, you know, just like it is, feel free to borrow and kind of amend things as it works best for you and your congregation. Also for the Living Well series, there's, if you want to get away from the paper, they do have an online option to get these emails sent to you on a daily basis through Lent. So if you prefer to get those emails rather than have an actual booklet, the website's listed on our agenda there. We gave out in January Alphabet Appetite, and that's what this one looks like. And this is more geared toward kids. It goes through the alphabet. A is for apple, and then talks about a little bit of a lesson that you can have to present to the kids. What do they have for Z? Just for fun. Y is for yogurt. Yeah, zucchini, you're right, yeah. So even those troublesome letters, figured it out. And again, you guys can figure out clever ways to use these resources. It might be for a children's sermon. Some of you help out in that way on Sunday mornings. And so anyway, these are here for you guys to use. And they're not in print anymore. We got these resources from the Church Health Center. when they were in Memphis, they were generating a lot of resources for us, so we've gotten permission to use those resources for free. Yay. There's COVID test kits, and again, help yourselves. I don't want to be packing these up and moving them here and then packing them up again to move them back to the office. So if you guys could help us with that, that would be great. And all the packet items that we have here in person. So we have about 13, 14 people here in person. You guys can't see them at home. We can see you guys. You're all up on the screen. And but just to let you know what the faces you're missing at home. And just a reminder to at our last meeting, Katie Kelly was here, Kathleen Kelly. She's the department assistant in spiritual care services. And if you or your clergy need to get a new ID badge for the hospital, if you have an old one, it doesn't work anymore. It will actually sound an alarm when you come through security at the front entrance. So if you want to switch them out, Kathleen is the one to talk to, and her number is on the agenda in addition to her email address. And also, if you or your congregation want to get set up with a weight tracker as an organization or as a team, Katie can help with that as well. And I did email her just before. She was hoping to be here today, but got called out with another commitment. But spiritual care is moving to a different location at the hospital. It's not going to be on the link anymore where it's been in the past. So it's on the first floor, which is close to the emergency room. They're moving in with palliative care. The department, spiritual care, is moving down with palliative care. But to make things more confusing, Katie is moving to a different location. Her office space is going to be in room 229. So if you're here in Robinwood, you know that far set of stairs by the Marsh Cancer Center, if you go to the top of those stairs, it's right at it's an executive suite up there with a bunch of offices. So they're going to figure out how they're going to handle communications between some of their departments. And so that whole area where spiritual care and cardiac rehab and the education center used to be, that's going to be crisis mental health beds. That's what they're converting that whole area into. And, you know, heaven knows mental health is just a huge issue for all of us, but a lot of offices moving, a lot of departments moving because of that, the addition of those beds.
Wendy, is that in addition to the inpatient mental health unit that they already have?
Yeah, so the question was, are the crisis beds in addition to the inpatient beds? And yes, it is, yeah. I don't know exactly. My understanding is it's much shorter term, you know, to get people like that need help in the emergency room, but need more. I mean, those folks are just going back into the community for to a certain extent, but this offers another opportunity to manage some of the folks that are coming in through the ED.
Mm-hmm. Is that going to be considered off-site, or is that, like, how's that going to work?
I'm not sure about, I think it's off-site because it's physically, but I don't know, with the link, you know, physically it is connected to the hospital, so I'm not sure, because you're right, with billing and all that, it becomes a whole, yeah, so we'll certainly let you guys know as we know more, but at least that's a skeleton of information to start with.
Wendy, did they see how many beds?
I'm sure somebody knows, but I don't.
Who is the coordinator of that unit? Do you have a name or anything?
Well, Alan is the executive director over it, and then I'm not sure who will be the manager of the unit, so more to come. Anything you guys want to share yourselves? Things you got going on in your congregations? Deb, anything you want to share from your network or?
We just finished up this little, I'll call it a review of the Daniel plan. And I don't have it with me, but I found a book at the library called about the wild space within, the wild land within. Anyway, it's a book on cultivating spiritual wholeness. Really a good book. And another book I got there that I had talked about using with our congregation is called, What Would Jesus Eat?
Oh, really? What would Jesus eat?
So
Yeah.
when I took that, the certificate for the health ministry with Tom, there was one session where they had people talk about what had worked for them as far as nutrition. And that's how I found out about the name of that book. And a gentleman talked about how he lost, I think he lost about 150 pounds after he read that. He had become sedentary and due to physical problems, he could not move. And he didn't know what to do. And somebody quoted him the scripture that God, anyway, that Jesus can do all things exceedingly above and what we expect. He thought of that scripture, and somehow he got a hold of that book, and it just made a life-changing experience. But yeah, so those are two things I'm kind of interested in as to how we can move our congregation to a different level. I want to go into something instead of just talking about diet or nutrition. I really enjoyed the Daniel plan because it incorporated so many pieces into it of wholeness. And so I really would like to move more towards like a support group so people can come in and talk about things that are really, what are other issues they want to talk about.
Yeah, the follow-up. Can you guys hear that at home, Deb Saunders?
Yes. Kathy asked what the name of the book was.
The name of the book, do you remember?
I will have to send it to you. I have it out in the car. I should have brought it in. But the tagline is Cultivating Spiritual Wholeness. DeLay, Lisa DeLay, I think is the name of the author.
Lisa DeLay is the author.
I'll send it to you and you can put it out. But
Yeah, Deb will send the exact title and
it's
we can.
It's just an excellent book, and I'll shut up here in a minute. But I get so excited about these things because it talks about how far removed we are from the original studies that people were doing when Christ was first here. And so we want to do things, and just the idea that we need silence, the idea of silence and our practice of bringing ourselves into that silence and different practices of prayer or spiritual practices that do that for us.
Mm-hmm.
So anyway, I'll send you the title.
Yeah, that'd be great. We'll share the title with everybody. Yeah. Susan, do you want to say anything about your the FAN, Faith Activity and Nutrition Program?
Okay, we had our kickoff, which was very successful. And we started that Sunday, our walk to Jerusalem. We're doing very well with that. We probably are in the Atlantic Ocean right now. Young couple who are competing with each other, they race to the treadmill every day. So people outside our church also taking. Let me see. We will be planning a tasting in March. The person kind of coordinating our nutrition is looking at introducing different foods and different flavors. I think when we finish up, I know we finish on Easter, the walk, but I'm not going to fool anymore with FAN until May. And then I think we're going to have some foods of the Middle East where we it up. And quite a number of us have joined up to walk this February 25th for the coldest night of the beach. We think that will help also give us more miles in it. So a lot have signed up for that. So I think it's coming along pretty well.
Yeah, great. And Tri-State Fellowship, they were also going to start the walk to Jerusalem. They're not going to do it over Lent, but they'll do it at a later date. And again, those resources are out of print, so I have copies, electronic copies of that stuff. So don't bother to call St. John's Hospital anymore because they're, after talking to 5 people and not getting anywhere, we've decided we're just gonna stick with the copies we have. We tried to give them our money, but nobody wants to take it. Anything else for you guys going on here in the in-person group? Are you feeling like your churches are kind of getting farther away from COVID with getting back to more of your regular stuff, or is it still a process? What's happening on that front? Are your congregations, like our church is nowhere near the membership we had before COVID, so are you guys experiencing some of the same things?
Yes.
A lot of nodding heads, yeah.
I feel, Wendy,
Yeah,
I feel like our church is really, people are just really coming back, and the youth have had a tremendous amount of kids come back, and they've had a lot of, I think they're doing a free babysitting opportunity this Saturday night. And I think there's 14 kids signed up to participate. So, I mean, I think there's more kids probably than they'll need babysitting for, but you know, that's just tremendous, you know, these days.
Yeah.
They're the future of the church, so.
yeah. Good to hear those success stories. It kind of gets us charged up.
Mhm.
Like,
I also, I starting January 31st, I have a free chair yoga class that started on Tuesday mornings at our church. And we have an average of 24 people coming every Tuesday.
wow.
So that to me is just tremendous. So.
Yeah, that's fabulous. Yeah. Congratulations. We're all excited on your behalf. Yeah. Oh, and before I forget too, I do want to ask for prayer to Barbara Cooper, who is at Virginia Avenue Church of God. She asked for prayer. Their son in his 30s died suddenly a couple weeks ago, and 2 young kids, and I don't know any more details, but please lift up Barbara, and her husband's a pastor at that church too, and just a lot of heartache, and just talked about that deep ache inside. And so she asked me to share that with you guys, because you guys are powerful prayers, so thank you for that. So we're coming upon the bewitching hour here. Let me, Sandra, you can hear okay, right?
I can hear you just fine. Good to meet you, Wendy.
Yeah,
And
you
everyone.
too. And just to let you know, beginning, we are approved for 1 AM2C credit for this, and Sandra doesn't have any conflict of interest. And she's coming to us from the land of 10,000 lakes. Does anybody know where that is?
Minnesota?
Minnesota, yeah. So it's ironic that Maryland is the only state with no natural lakes.
Oh.
We have lakes, but yeah, we made our own. So you bring that water resource that, we've got the Chesapeake Bay, but we've got more salt water than fresh water in our region. So, and Sandra will be talking to us about trauma-informed care and faith community nursing, and actually she's the lead person that handles the teaching of their course in Minnesota and for her particular region. And they've actually added this on as a module in their foundations course. So all of you that have already attended the course, we're getting you caught up here. And Sandra, they all told me they've figured that they've filled out their ACE forms, so they're well equipped in that way. And Sandra's been a faith community nurse for about 15 years in 3 different congregations. She has her bachelor's in nursing and her master's in adult education. And she just recently completed a certificate course in this topic of trauma-informed care. So, Sandra, we'll turn it over to you. You wanted to, let me,
I'll
so
share
if
the
we put,
screen so I can advance. But let me just first of all say what a thrill it is to be here. Anytime I get a chance to listen to what parish nurses and faith community nurses are doing in other parts of the country, it's just a thrill for me. And I want to thank each and every one of you for all that you do to serve and all that you do to help people wherever you are. So thank you, Wendy, for asking me to be here. I'm going to share my screen now with the slides, which let's see, you'll have to, I think, give me co-host ability, Wendy.
oh, silly me.
So if you go into participants, I think you can give me
Yes.
co-host. Okay, great. There we go. Wonderful.
We're loving your pink top there. It's nice and
Oh,
bright.
thank
Good
you.
for, and then you guys here, you've got copies of her slides as well, so you can follow along. And it is posted on the website, the protected part, if those of you that are listening remotely want to look at them later.
And I believe here, I'm just going to have to go back for a minute and be sure that I've got my on now that here we go. All right. And now we'll go to this. How many people do you have in person and how many do you have on Zoom today?
I think we have 14 in person and what do we have?
5.
5 or 6 at home?
Okay, great. Can everyone see the slides?
Yes.
Okay, good. All right. Well, as I said, it's such a privilege to be here with you. And just a little bit more about why I got interested in this area. About 3 years ago, I had the opportunity to attend a 3-day conference on trauma in faith communities that was offered to clergy and faith community nurses by the Sidran Institute. And that's the first time I was really awakened to the prevalence of trauma and how it really impacts people in the world and most certainly in our faith communities. Being interested in that, I then attended a pretty intensive online program on trauma-informed care and became certified as a trauma-informed care practitioner. But to be completely transparent with that, I don't in any way consider myself to be a therapist in the area or even a real expert in the area. What I've found is that it's pretty loose, this certification process for trauma-informed practitioners at this point. And as we talk about referring people for therapy or more help, we need to be really careful that we are researching what kind of background these therapists have in this practice. Our outcomes today, you can all read them, but I think it's important that we understand what trauma is and what we mean when we talk about trauma-informed care, trauma-informed practice. We're going to talk a little bit about the adverse childhood experiences, and thank you for taking that short quiz. We'll be watching a video that really talks about where that came from and why it's such an important piece of research. We're going to look at some different types of trauma and as faith community nurses really take a look at the spiritual implications of trauma. I think you'll be amazed to know that estimates are that probably 1 out of 4 persons in faith communities has had at least one serious trauma in their life. And so we need to be aware of the spiritual care that those individuals need. And again, how can we promote healing? So what do we mean by trauma? And of course, years ago when we thought of trauma, we thought of trauma centers and hospitals, places that were really set to fit traumatic accidents and other events. But the definition now, as we use it, is an event or series of events or set of circumstances experienced by an individual as physically or emotionally harmful or life-threatening. And this is the important part, it has lasting effects on their physical, emotional, or spiritual well-being. So it's not just the trauma at the moment, but it affects that person weeks, months, years after this series of events or circumstances occur. And of course, trauma-informed practice is being patient-centered as we approach the healthcare for these individuals and provide care in a way that prevents re-traumatization of patients and staff. So we'll talk about how, unfortunately, faith communities often unknowingly can re-traumatize members of that church or synagogue or wherever it is that you're practicing. Now, I would guess that almost everyone here has experienced some degree of trauma in your lives. It definitely is something that any of us can experience. And if we haven't ourselves, we know someone who has. We've had clients who have told us about traumatic experiences in their lives. So lately we're seeing a lot of weather-related disasters where people's homes, their livelihoods are destroyed in a tornado or a hurricane. We certainly are aware of very serious car accidents where there's a result of death or massive injury. And we probably know clients who have suffered child abuse. And whether that is sexual abuse or whether it's, physical, emotional abuse, we certainly have run into people who have told us about those experiences. Are there any examples that any of you could just quickly cite that you've met a client or someone that has told you about trauma in their lives, or if you feel comfortable relating a trauma that you've experienced, just so we can have some examples? I can't see all of you, so, well, think about that and we'll have another chance as time goes on to maybe relate some of the experiences that you've heard, and I'll be giving you a lot of examples. What I'd like to do now is play a short video for you that talks about ACEs, and I think this will really summarize for you, hopefully, why this is something we all need to understand. So let's all pray that this works. We never know with these videos. Go. All right, I'm gonna get rid of this and see if I can advance it in a way that it will work for us.
We can hear it but can't see.
What does your parents' divorce have to do with your risk for heart disease? If your mother had a drinking that can happen to a child growing up.
There we go.
Some experiences are so stressful that they can alter brain development, as well as the immune system, increasing the risk of lifelong health and social problems in adulthood. The term comes from the Adverse Childhood Experiences Study, landmark research that shed new light on the root cause of everything from stroke and liver disease to substance abuse and mental illness. In the late 1990s, an epidemiologist from the Centers for Disease Control and a preventive medicine doctor at Kaiser Permanente set out to understand the association between childhood experience and lifelong health. They asked over 17,000 people in the Kaiser Health Plan in San Diego about their health history, as well as difficult questions about their experiences growing up. Anda and Felitti tallied up 10 different kinds of adversity in this largely middle-class and college-educated population. They were stunned to see how common ACEs were. 21% of all respondents were sexually abused as children. 19% grew up with someone who suffered mental illness. 28% had been physically abused. And 2 out of 3 respondents had experienced at least one ACE. The researchers next looked at how someone's ACE score, or the number of adversities they experienced, related to a wide array of serious health and social problems. They saw that the more ACEs someone had, the greater their risk for poor outcomes compared with someone with no ACEs. Someone with an ACE score of 4 had twice the risk of heart disease and cancer. Someone with an ACE score of 5 had an 8 times greater chance of being an alcoholic. And those with an ACE score of 6 or more, on average, died 20 years earlier. With every major problem they looked at in the ACE study, the risk went up for each additional adverse experience in childhood. As Dr. Robert Anda says, what's predictable is preventable. It's important to remember that ACEs are not destiny. ACEs are a tool for understanding the health of a population as a whole. For individuals, an ACE score can be a tool for understanding their own risk for health and social problems, and empower them to make changes for themselves and their children. ACEs tend to get passed down from generation to generation and are common across all income levels, races, and cultures. But increasingly, people of all different professions and backgrounds are coming together to discuss how ACEs affect their communities. They're finding new ways to treat and prevent ACEs. Many doctors are starting to screen their patients for ACEs as part of their medical history. More schools are becoming trauma-informed, considering the source of problem behavior when disciplining their students, instead of immediately suspending or expelling them. To learn more about interrupting the cycle of adversity and improving health and well-being for the next generation, please visit kpjrfilms.co.
All right, just to give you an idea here of, whoops, we got to stop that now.
Your risk for heart disease.
So we're going to move on now to.
If your mother had a drinking problem when you were growing up, are you more likely to suffer from depression as an adult? Here's what you should know about ACEs.
Sorry that I can't. There we go. I need to get out of there now and get back to our other screen. So let me do that. Okay. So just from that that video gives you a background, I think, on what we talk about when we talk about these adverse childhood experiences. And if you took the quiz, which it sounds like you did, the ACE questionnaire, you got a feeling for whether you had any trauma during your childhood. Just so that you know, the initial study has now been redone many, many times with new groups of people, and it has been validated and certainly is becoming very well known as a important and study that really helps us with this whole idea of ACEs and what that means.
Sandra,
Yes.
Wendy's put something in the chat that they aren't able to hear you. So I think the people online can hear you, but the room can't hear you.
Really? Okay. Thank you for letting me know. I don't know why that would have suddenly happened, but I will go back and see if I can fix it for you.
They also apparently they could see the video, but they couldn't hear the video.
Oh, dear, dear, dear. Okay. Well, I will send that to people later.
Oh, there,
So,
she's showing a picture, no sound. Wendy is holding up a paper that says no sound.
can you hear me now, Wendy? Okay. So let me just get to Wendy and see, because I haven't changed anything on my end here. So Wendy, if you can hear me, please let me know. I've got my volume up here all the way. Let me know if you hear anything from her chat that would somehow tell me that she can hear us. I'm going to ask Wendy if she can go back out and come into Zoom again, or if I should do that. Oh, they were having trouble before we started our meeting. Interesting. Okay. What would you folks like to do? Shall we continue on, or those of you on Zoom? So sorry, I have my, so you on Zoom can hear me, is that right? Okay, so that's odd that people in the room can't hear me.
It
But,
looks like they might be, it says connecting to audio, the folks
oh,
in
okay,
the room. So
thank
maybe,
you.
um,
I don't know if they're using an OWL meeting or just what they're using to connect, but I think what we'll do, folks, is just keep going here, simply because I definitely want you to get the information. And if I have to do this again, that's fine too. We'll figure that out. So when we talk about trauma, I think it's important to know that there are many different types of trauma that can occur. There's that single incident, and you can see some of the examples of single incident, the serious car accidents, the national disasters, sudden loss, a single episode of abuse or assault, all of which are very traumatic to people, but are a little bit different than repetitive trauma. And this would be something that happens over and over again. So we think about children who are repeatedly abused by their parents or a family member or someone else. We're thinking of the spouse who is a victim of domestic violence. We're thinking about situations like war. And when you watch the news about the Ukraine war right now, you can see the trauma in the, I think, physical and emotional pictures of those individuals. And certainly those of us who are involved in very high stress situations, um, in hospital settings or in the emergency room or other places, we are vulnerable to repetitive trauma. And we've been hearing more and more about that, certainly during COVID and the shootings that are happening, how not only the people themselves who are being affected by the trauma, but the people who care for them can definitely have vicarious trauma. And I had a student in the foundations course, the last time we offered it, who had been working in intensive care during the entire COVID pandemic. And she spoke of the trauma that she had experienced as a critical care nurse during that time. So again, think of clients or patients you've cared for who might have experienced these types of trauma. And I do think that COVID-19 has qualified as a type of trauma for really for all of us in many ways because of the uncertainty that it created in our lives. Please interrupt me if you do have questions here because I know it's possible that I'm not seeing you or always catching the chats as I'm talking. Developmental trauma is another type of trauma, and this is children from birth to 5 years old. They might have ongoing repetitive trauma, physical, sexual, emotional, abandonment, neglect. These children might have witnessed violence or death, coercion, betrayal. And what I think is important for us to understand as nurses is that this type of trauma has a very direct change on the developing brain. It impacts the child's ability to learn, to problem solve, to control their impulses. One of the things I learned in the course was that oftentimes young children will go to school who have been living in a traumatic environment and have had experienced trauma, and they are unable to focus and learn. And the reason for that is that when we are exposed to trauma, the amygdala, the primitive part of our brain, gets hijacked. Those children may live in constant fear. They live with the constant stress response going on. And that portion of the brain is so overactive that they cannot switch to the more frontal lobes, to the cognitive part of their brain. So when we ask them, to sit down and learn their numbers, their letters, or other topics, they're not able to make that shift to the cognitive part of the brain because they're in a state of stress. And that really helped me understand. I volunteer in a childcare center where we have several children who come from backgrounds where there is trauma, and we know about that trauma. And you can see the ability, the lack of those children's ability to be able to control their impulses, to control their emotions, their ability to really focus and concentrate is definitely impaired. There's also historical trauma or intergenerational trauma, and there's a lot of research going on with this. And the premise here is that as races or cultures or ethnicities have been bullied or treated in, very, very negative ways for generation after generation, there may be some actual brain changes that happen that are passed down genetically from generation to generation. And more research is needed on this, but it would explain many different things if it does show us that trauma doesn't just stop with one generation. I like this quote by Dr. Charles Nemiroff because I think it sums up what we're talking about here. He said that trauma is the single biggest contributor to the risk for psychiatric and medical disorders more than any single gene or factor. It increases the risk for heart disease, stroke, depression, drug abuse, suicide. It's simply awful. And we need to be aware of that because for so many years, we haven't understood that this is a major factor. As the film told you, persons with 6 or more adverse childhood experiences reduce their life expectancy by 20 years. And that doesn't even speak to the medical costs, the healthcare costs of treating individuals who have experienced trauma in their lives. I've thrown in a few resources here in the slides that you can look at later, but I think there's many resources out there for further study. Some of the physical impacts of trauma, and I think these are probably easy for us as RNs to identify, but certainly abnormal adrenal activity. We all know the stress response. We know what happens when we're in a fight or flight state. And so trauma is that maybe times 10. Cortisol is flowing, adrenaline is flowing, other stress chemicals. We're seeing a weakened immune system. We're seeing changes in the brain. In children, the ability to form new neural connections and pathways can be disrupted, but even in adults, many adults who have been through trauma get stuck in this primitive part of the brain, and it makes it difficult for them to step back and get any sort of perspective on what's happened because of that. Many people have physical pain. It's hard to say how many incidences of back pain or migraines or other types of pain, abdominal pain, could be the impact of trauma. Certainly panic and anxiety attacks and higher incidence of all types of chronic diseases have been associated with trauma. I'm hoping that you can do a little work for us here too as we talk about the ways trauma could impact spiritual and emotional health. So let me just stop sharing for a moment and see if those of you on Zoom at least can talk to me about this. Wendy, are you back? Can you hear me now?
Yes, we are.
Oh, how much have you missed? I'm glad to do this again for you if you missed a lot.
No, we cut out toward the beginning of the video, and then we got you back, probably into your third or fourth slide. So we're
Okay.
catching the majority of it.
That's great. Well, I don't know what happened on this
You don't
end.
have any more videos, do you?
No, I do not. So that's probably what did it. So the question that I'd like to pose to any of you, and you can use the chat if you don't want to speak up, but what do you think are some of the emotional and spiritual implications of persons who have experienced this type of trauma? And that can be from your own experiences or from clients that you've seen.
Well, I think all of us have just dealt with folks that are just, anxiety is just, a lot more of an issue that I notice my kids and their generation is a lot more prevalent.
When you have a feeling of hopelessness because you're in school, you're following the rules of teachers, your friends, and you know that when you go home, if you're having trauma at home, it's still there. So for little kids, even after middle school, for them to like shunt it off, they can't do that. And she did say that, changes to the brain occur. So if you've got hopelessness, it doesn't matter whether you're not doing well on your spelling test or whatever.
Yeah. Exactly. Hopelessness would be a spiritual sign. As we think about what are spiritual needs that our clients have, everyone has a need for hope, right? And people with trauma often can't find hope. Great example. Any others? How do you think they might feel about their God or their faith if they've been traumatized in these ways?
Lose faith, they would lose their faith.
Sure.
Become bitter, anger at God, blaming God. I mean, seeing it a lot.
Yeah.
But that's why you need crisis counselors to help people through
That's right.
these traumas. And it works good, I think, in short-term traumas that are short-term or haven't been repeated many times. They're deeply embedded in a person. It works good for relieving momentary instances of trauma for support. But when you have the abuse or the neglect or whatever over and over, that's when it's real tough to try to manage that type of long-term trauma.
And as faith community nurses, we are not trained or qualified to do that. We can do some things, and we'll talk about those, but we do need to go to those resources and hope that people are open to it. Many people have trouble being open to therapy, being open to getting help. But you're absolutely right. That is true. Let's take a look at some other spiritual walk down here to the somebody's phone is ringing. So most definitely here, loss of faith and beliefs. So trauma can cause a person to believe that a loving God is not going to protect them or doesn't love them. How could an all-powerful God allow this to happen? And I've certainly heard this from my clients as a faith community nurse. You know, this a recent story was that I had a client and his a couple whose 30-year-old daughter was murdered by a complete stranger. He broke into her apartment and brutally murdered her. And this couple was so traumatized and continues to be so traumatized by this. And they've really questioned how God could allow this to happen to their daughter and to them, and are struggling 3 years after this. And they're just now starting the trial of the person who murdered her. So you can see this long-term trauma and the impact that it's having on them and how they're responding. Many people with trauma experience guilt and shame. They somehow believe it was their fault. They feel worthless. They feel humiliated. You see this often in persons who have been sexually abused, persons who have been raped. And it's heartbreaking to see how people blame themselves. They're emotionally overloaded. Many of them feel numb. They can't really feel emotions at very many times. They and sometimes they dissociate and are just they act kind of like they're frozen. There's very little emotion going on. We definitely see anger, depression, anxiety, a lot of outbursts and other behaviors that we can't understand can occur, and clearly impaired judgment. You know, sometimes I think we look at different populations around us and the kinds of things that they do in their lives, and we say, how could they make such poor decisions over and over again? And we need to begin to ask ourselves, is there something that has happened in their life, something that is currently happening in their life that is hijacking the primitive part of their brain and causing them to only be able to focus on survival? They cannot mobilize the thinking part of their brain to make good decisions or to solve the problems in their life. Many people who have been traumatized feel very incompetent. They feel, again, a lot of self-doubt in their lives. So I think this understanding fosters in all of us a higher degree of tolerance, a higher degree of kindness, a higher degree of gentleness. I'm not going to spend any time on this, and it wasn't in your slides. If you'd like to have it, I can certainly send it on to Wendy, but I was interested to see this in this source. And it talked about existential reactions, which we could really translate to spiritual. But notice that they could be different. So someone might go through trauma and intensely start using prayer and have a restoration of faith because people have come to their rescue in a traumatic situation. But they also can have despair about humanity. And it will disrupt their life assumptions that life should be fair or good or predictability. And then there are also the delayed existential or spiritual reactions, loss of purpose, hopelessness, cynicism, disillusionment. All of these kinds of things can occur. Complex and wide-reaching. Now, the adverse events really focuses on kids 0 to 18. But I recently attended an excellent seminar that reminded us that the effects of trauma can occur at any age. And I know many of us work with, people that are adults or older adults, and we need to understand that trauma experienced at any age causes disruption in neural function and immune function. I was very interested to see that serious illness or being in critical care units causes trauma. And this is something we don't really think about very much, but medical trauma is often, medical trauma is often hidden. Some studies say that 34% of all patients who are in ICU experience some degree of post-traumatic stress disorder. And part of this comes from either being sedated, being restrained, being intubated, feeling like they've lost all control. And rarely do people in the hospital or critical care units ask these individuals about fear or worry or sadness. One of my pet peeves is that we ask people when we work in the hospital almost every shift, tell me what your degree of pain is. And we have that scale, 0 to 10. But how many people stop after that and said, how are you doing spiritually? How are you doing emotionally? On a scale from 1 to 10, where 1 is you're feeling hopeless and you're feeling scared and you're worried, and 10 is I'm feeling okay about things. I have hope, I have trust. And I think as faith community nurses, we can be very attentive to this, particularly if we're making visits at the hospital or in facilities, or when we are talking with people within our congregations who have had major surgery or have been hospitalized. I was also interested to see that the process of aging can often reactivate old trauma memories when our health starts failing. And the point that was made in this particular seminar was that people with dementia, often when we see them acting out and becoming belligerent and becoming, very, very restless and those kinds of behaviors, it's possible that they are reliving their trauma memories from way in their past. Many people who are in elder care have experienced sexual violence in their lifetime. They probably have never talked about it because at that time when they experienced it, it was taboo to tell other people about it. But we shouldn't assume that trauma goes away when we get older or when we start having memory issues. And I think many of us, if we can be aware of that, can also be aware of, what we as practitioners and faith community nurses can do to help people in these situations. Which brings us on to, how can we promote healing? And one of the things we do best as nurses in general, and I think as faith community nurses, is to be open to them talking to us, to really truly listen and give these people time. Let them talk at their own pace, not rushing them, not pressuring them. Avoid asking, what's wrong or what's wrong with you, but instead tell me what happened to you. And and to approach that with acceptance of their feelings, not judging, not blaming them, not criticizing their reactions to this trauma. try to use the same words they use. So, I've been frightened ever since of authority figures, or, I have a hard time whenever the tornado sirens go off because I was in a tornado at one time, or we lost our home, or, any variety of things, trying to mirror what they're saying. Never dismiss their experiences as well. I know a lot of people who have gone through this and they've made it through. Um, really being open to listening very, very deeply, listening with body and soul and mind, and that authentic presence that is so important in our practice. Don't give advice, only if you're asked to, and then be very, very careful because, again, this is not our expertise as faith community nurses. And it's okay to say that. It's okay to say, I'm not an expert in helping people who have experienced the kinds of things you have. I can certainly work with you to find someone who could help you. Now, I want to just say a word about touch with persons with trauma. And in the recent workshop that I was in, the instructor said, I'd like you to find a person sitting next to you, and I'd like you to designate one of you as the toucher. And the person who is the toucher, I want you to just touch the eyelid of the person sitting next to you. And you could just hear in the classroom, the sounds of people saying, no, 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 don't do that. And then she said, how different would that be if you said to your partner, I would like to touch your eyelid in a moment, and I wonder if that would be okay with you if I did that? She said, would that make a difference in how you received that touch? And of course, her point was, many, many people with trauma are very sensitive to other people touching them, particularly those who have been abused, sexually abused, beaten, domestic abuse. Do not assume that touch is okay. So you might say, I would like to hold your hand. Is that okay with you? I would like to, touch you on your shoulder. Is that okay with you? And I thought that was very helpful because sometimes we assume everyone likes that touch and finds it comforting. Certainly keep learning more about this. I think there are great resources out there. There's free online programs on this happening all the time online. If this is something that you're interested in from even our conversation today, keep learning more about it. Examine your own feelings and beliefs and recognize that we sometimes have biases about this. We think, why can't people just get over this? Why can't they just leave it in the past and embrace the future? And we really need to look at those notions about trauma. Examine your own trauma and the experiences you've had. Certainly, I experienced sexual abuse by a brother when I was growing up. I repressed that sexual abuse until I was a young adult. And when it came out, it was just frightening to me. And no one in my family knew about this. So I think if you have experienced something like that in your life, get help. It will help you also as you serve others. Help inform your faith community staff and leaders of what trauma is and how it can impact people within your faith community. When I started learning about this, I asked if I could do an adult forum on the whole issue of ACEs and trauma, and I got approval for that and brought in a speaker who brought the ACE inventory for everyone to do. And we had about 80 people attend the forum. And after the forum, I must have had a dozen people come up to me individually and say, I had no idea that the trauma in my childhood could cause these types of emotions that I'm feeling today. Thank you for bringing this in. It has given me the freedom to say there's nothing wrong with me. The way I'm feeling is a normal response to trauma. I also mentioned, it's very likely that 1 out of 4 members will have experienced at least one traumatic event, and certainly many with more than one traumatic event with lasting effects. So keep this in mind as you do your initial assessments and follow-up assessments of people. And obviously, avoid judgment, stigmatization, re-traumatizing. Be aware that coming into a faith community can be a real time of threat for some of these people. They're afraid that they could be stigmatized or judged. I have an example of that happening in a faith group in one of the congregations where I served. They had many different faith or small groups that would get together periodically, actually quite frequently, every couple of weeks. And I had a woman come to me after being in a faith group, and she told me that she thought she could trust her faith group, and she confided to them that her husband, who was also a member of that church, was having an affair. And she was completely taken aback by the response of the people in the faith group, many of whom defended her husband, said things like, well, I'm sure he had no intention of hurting you. One person said, I think we should all pray that you can forgive your husband. I mean, it was totally re-traumatizing for this woman, which is why I personally believe that faith groups and support groups that meet within churches need a facilitator who's trained to facilitate these groups, because I've heard many examples of people who have been deeply, deeply hurt by persons who just don't know any better and will say things that are very harmful. We can help survivors seek meaning and forgiveness, and most definitely assure them that God loves them, but be aware not everybody's ready to hear this. Refer to experts. Um, Protect. Faith communities need to be safe places. If you don't have policies against sexual abuse and prevention of sexual abuse and a protocol for how to handle that, those are things a faith community nurse can, be the impetus for within a faith community, and speak up against any injustice or abuse of any kind. Um, know that healing comes very, very gradually, very slowly, and for some trauma survivors, healing is elusive. They're not able to find it, so they need to, keep working at it, but that we understand that this is not a quick fix for many people, depending on the depth of the trauma. I don't know that we're going to have time for this case study. I had hoped that we could discuss it a little bit. But in this case, just imagine that a client of yours came to you diagnosed with breast cancer. You're praying with her, she breaks down crying, and she talks about sexual abuse that her father repeatedly did during her childhood, and says, I know God is punishing me because I never forgave my dad before he died. And think about, as a faith community nurse, how would you approach this with this woman? What, now that you've heard some things about trauma-informed approaches, would you listen? Would you ask her to tell you, if you're comfortable, please tell me what happened? How can you, provide reassurance in this situation, and, find other ways that you might help her as she goes through the breast cancer diagnosis as well as with other painful trauma. This is I think, really powerful quote. Trauma is personal. It doesn't disappear if it's not validated. When it's ignored or invalidated, the silent screams continue, internally heard only by the one held captive. When someone enters the pain, and hears the screams, healing can begin. You know, we are that someone that can hear the pain, validate the emotions. And Bessel van der Kolk, and I highly recommend his book, The Body Keeps the Score, says, how can people gain control over the residues of past trauma and return to being masters of their own ship rather than letting the trauma control what's going on with them? So let me stop sharing. I want to thank you for the privilege of being with you today, but I really like to open it up for questions if we can. And Wendy, if you've got either questions from your group or if people on Zoom want to ask questions or put them in the chat room, we've got about 8 minutes or so for that right now.
Yeah, and we will, just a little amendment on that. We'll probably need to just have a few questions, maybe 2 questions, and then, the room that we're in at the hospital, we need to get out of here, because there's another
okay.
group that, wait, and then we just learned wasn't on the calendar when we, earlier today, so
That's
anyway,
happened to me too. Okay.
sorry
Well,
about that, but.
and you know, Wendy, make my email available to people. If people have questions, I'm happy to answer them by email too. Can we take one question? Does anybody have a question about this discussion today?
I think one thing that comes to mind for me, like I think of my dad that was in the Korean War, and, you know, I think it became more evident with Vietnam vets that were coming back, but, you know, we never talked about this with our parents, and some of our parents would have been World War II or, certainly the Korean War. Is it just that, you know, I know my dad self-medicated with alcohol, so that, you know, could have been part of the, you know, his drug of choice, but, has it always been around and we're just more aware of it now, or what's your feeling on that?
Well, I think it has been around since the beginning of time, and certainly people who served in wars, we've seen it used to be called shell shock, right? I mean, it's been around. I think we're definitely recognized post-traumatic stress syndrome several years ago. I think the ACEs study just, you know, blew things out of the water to realize that there were consequences health-wise for people who were experiencing trauma early in life. And so the research continues on that. You know, obviously, if we could prevent some of the trauma, you know, we have to go back to that story of us sitting by a river, watching people, you know, go by in the river, struggling to swim, and they're all drowning in the river, right? And we're trying to save them all. But that story goes, who is at the beginning of the river pushing all these people in? And as we look at our society and we see young children being born into poverty, we see them being abused, we see them, you know, being treated in ways that doesn't foster a healthy life. We got to figure out some ways to prevent the trauma as well as treat it. And it's a big challenge for all of us. So as faith community nurses, I'd like us to, you know, pick up the torch and begin to help people understand the ramifications of this in our society and world.
Yeah, well, thank you. It's, well, it's so nice to have your resources too, to just read more about what, you know, what are the best ways to accompany people through the journey, you know, whatever it is. And I think the church certainly has some accountability factors too, because the church has caused trauma for a lot of folks in a lot of our own denominations where we've had sexual abuse among the clergy, and the church has just been a very hurtful place. So we're very grateful for your presentation and look forward to diving into some of those great resources that you gave us. So
well, and I do
thank you very
apologize
much.
I apologize so much for the audio. I'm not sure that our Zoom people could hear me. For some reason, you couldn't in your room. But if there's anything I can do to make up for that, please let me know, Wendy, and I'm happy to do
Well,
that.
and that was all on our end, because this particular room at the hospital is always troublesome.
Oh,
So you did everything right, and we're just trying to navigate for everybody. So thanks anybody for your patience at home and here. And just a reminder too, if you're at home, we'll send out an email Survey Monkey link for the evaluation. So you need to complete the evaluation, and don't forget to, that last question asked for you to include your credentials and your email address. So we'll leave that Survey Monkey evaluation open till the end of the month, and that's how you get your AMCC credit. And for those of you here, we've got the paper evals, if you could fill those out and kind of complete that process. But Sandra, thank you very much for making time, and can we give you a
Thank
round
you
of
so much.
applause?
It's just a joy to meet with all of you. And if there's anything I can do for you in the future, please let me know. Appreciate it. Thank you.
I don't know, can you see our group here?
I do. Hello, everyone. Thanks for all that you do. Bye now.
Well, you do a great job of talking to the screen, so Sandra, thanks a bunch. And we'll see everybody. Next meeting is in March. We're back to the evening, 7 to 8 time, so I believe, what is it, March 16th? And I'll keep you informed about the details of that. We're still pulling that together, but March 16th, and that will be both in person at Howell Road or via Zoom. It'll be both hybrid, with in person or remote, so you can choose from there. So we're going to wrap it up here and clear out the room. But thanks everybody at home. It's great to see y'all. Take care.
Thank you.